Everyone. We are absolutely delighted today to have Dr. Stephanie Deutsch from Nemours to give us a talk on screening children for child abuse. But before I introduce her, let me mention some housekeeping issues. We will continue extending CME credits for our Tech Talks and our ID series presentations. All the information will be distributed via email to those that who registered today. If you did not register prior to today's talk, you can still obtain CME information from Lisa Maturo at ACCEL, and I entered her email address in the chat. Our April 9th ID series will be Kimberly Williams from ACCEL, from our team in the Value Institute, and she will talk about practice-based research networks, a potential catalyst for clinical and translational research in Delaware. And then on May 6th, we'll have a tech talk, and it's also one of our own, Rizali, also from ACCEL, and her title will be forthcoming. So again, I'm really delighted and honored to introduce Dr. Stephanie Deutsch today. Dr. Deutsch is a section chief of the Child Abuse Pediatrics Program at Nemours, Dupont Hospital. She is also the co-medical director of CARE, which is Children at Risk Evaluation Program, and assistant clinical professor in pediatrics at the Sidney Kimmel Medical College in Philadelphia. She received an MD from New York Medical College, and she did her residency in pediatric medicine at the Children's Hospital at Montefiore. She did also a fellowship in child abuse in pediatrics at the Children's Hospital of Philadelphia. She belongs to multiple committees in the state working on child protection and child abuse investigations, and she's had many awards, the last one in 2020 for the overall academic achievement and academic excellence from the Division of General Pediatrics at Nemours. Her focus is on developing child welfare policy and best practices for prenatally substance-exposed infants, as well as quality improvement initiatives to standardize abuse evaluations across hospital systems. She already has a very large number of publications, and she's a sought-after speaker regionally and nationally. So, Stephanie, we are really honored to have you giving us a talk today, and thank you for being here.
Good afternoon, and thank you, Dr. Jerkowitz and the members of the ACCEL program for extending this invitation to me to present. I'm thrilled to be here and have the opportunity to share with you really the exciting work we've been doing to understand cost implications of child physical abuse evaluation standardization here at Nemours. Here's just a little bit more about me again. I've been in practice now for approximately 11 years, with 8 of those years focused specifically on evaluating suspected child abuse and neglect victims, both at the Children's Hospital of Philadelphia and here at Nemours. And for housekeeping, I have no relevant financial disclosures or conflicts of interest, but I will disclose that I routinely engage in expert witness consultancy work for child abuse cases across the country, including authoring expert reports about abuse diagnosis and testifying as an expert witness in both civil and criminal legal proceedings. So regarding the goals of our talk today, I'll start by spending some time putting this topic into context for you, since many of you practice adult medicine or are focused more specifically on adults in your academic pursuits. We'll briefly review some child abuse epidemiology nationally, some pertinent injury biomechanics, and then I'll relate both to the key abuse screening evaluation components recommended currently in national clinical best practice guidelines. I'll address some disparities in abuse evaluations and then the historical efforts to mitigate these disparities, which include implementation of clinical pathways and other care standardization tools. I'll focus a little bit on the societal impact of child abuse and neglect, but then spend the bulk of our time really focused on my current research, use of a novel financial analysis technique, time-driven activity-based costing, to understand the cost ramifications of child physical abuse in the hospital setting. All right, so let's get started. As you well know, child abuse is not a novel issue, and in fact, throughout history for thousands of years, the maltreatment of vulnerable children has been recognized as a persistent theme. I've listed here on this slide a brief timeline of child abuse medical legal recognition within the U.S., with the first case of child maltreatment prosecuted in 1874 and the coining of the infamous term, the battered child syndrome, by Dr. Henry Kemp, a pediatrician, and the first really in the medical community to identify and recognize child abuse. In 1962, Dr. Kemp published his famous paper, The Battered Child Syndrome, which led really to the identification and recognition by the medical community of child abuse and gave medical providers for decades really to follow appropriate terminology to use when diagnosing child abuse victimization. In 1974, federal legislation aimed at defining child abuse and allocating monies towards addressing issues of investigation, prosecution, and prevention was passed, known as the Child Abuse Prevention and Treatment Act, or CAPTA, really defining at a federal level what constitutes abuse or neglect, but allowing all 50 states, the District of Columbia, and the U.S. territories then to develop separate permutations of this definition at the local jurisdictional level. So what we know about child abuse epidemiology nationally comes from the National Child Abuse and Neglect Data System, which is a federally sponsored warehouse that collects and analyzes data submitted voluntarily by child welfare agencies across the country. Annually, a federal report is commissioned to provide status updates on abuse and neglect statistics, primarily including cases that are substantiated, meaning that they meet the local jurisdictional statute burden of proof, or the civil definition of child abuse or neglect in the respective locale. So obviously these two features, the voluntary submission nature and the select cases included in the report, likely represent a gross underestimation of the true prevalence of child abuse cases in our community. And while we don't have too much time to spend on this, I just wanted to give you a snapshot of abuse epidemiology based on fiscal year 2019. So the available federal data suggests that nearly 3.5 million children across the U.S. were involved with the child welfare system, either through acceptance for investigation or provision of family support services.
Seems that we lost Dr. Deutsch.
Can you still hear me?
Oh, yes. Okay, now we can hear you. We lost you for a few minutes.
Yes, unfortunately, our power just went out in the Rockland 2 building, so I'm sitting in darkness and I have a black computer screen here. So bear with us for a moment. Hopefully the power will be restored.
Oh my goodness.
We are still without power here. Bear with me for one moment.
On my phone, but like I do it on your
So my laptop's not.
account. Okay.
Our audio still projecting?
Yes.
Yes, we can hear you.
Okay, well, I have a manual copy of the slides on my end. If one of you, if someone would advance the slides, potentially I can still keep going.
Lisa, is it something that you can do to advance the slides?
I would have to actually, she needs to stop sharing and I need to bring up the slides on my end, which she had provided me.
Okay. Would you like to do this, Stephanie?
There we go. Well, I have no way of stopping sharing because I am
Oh, you are black.
Yeah, so wait a minute. Let me see if I can do it from here.
I'm sorry, everyone, while we are resolving this issue.
I'm able to do it, so just give me a few minutes while I get her slides.
Okay.
Yeah, so unfortunately, I can't see anything over here because I'm sitting in office darkness with my screen, but I remarkably can hear you somehow. Okay, if you are still able to hear me, I am attempting to pull up.
Yes, we can hear you.
Okay, I'm attempting to pull up slides on another device. Our internet connection here is in and out because of the power. Our power has not been restored over in Rockland 2, but I will pick up where I left off. Let me just pull up the PowerPoint from this.
Oh, okay.
My sincere apologies for this.
Sorry, this is
Bizarre.
what happened.
We are all sitting in darkness over here. Our power is coming back on.
Oh, that's good news then.
Okay, so my screen is back up. I can see my screen. Are you still able to see my screen?
We see your screen, but we don't see the slides right now.
Okay, I will.
Perfect.
Okay. Right, well, moving right along. So as I had mentioned, the available federal data suggests that nearly 3.5 million children, here we go. The available federal data suggests that nearly 3.5 million children across the U.S. were involved with the child welfare system, as I mentioned, either through acceptance for investigation or provision of family support services. It's really a fraction of those cases, nearly 660,000, meeting a threshold for substantiation, that burden of proof by statute. That renders about 8.9 per 1,000 U.S. children to be victims of child maltreatment across the country annually. In fiscal year 2019. 4/5 of those children suffered a single type of maltreatment, 61% of whom were neglected. You see the percentages for physical abuse and sexual abuse are much smaller. So really the vast majority of U.S. children experience neglect. and the percentage of children experiencing physical and sexual abuse are comparatively much lower. Infants, those less than 12 months of age, not surprisingly, are the subset of the pediatric population that's most vulnerable to maltreatment, reliant nearly entirely on their caregivers for fulfillment of all basic needs, with little independent mobility. They're easy to pick up, to shake, or to break a bone. And so abuse victimization rate for infants nationally has hovered consistently over the past 5 years, around 25 per 1,000 infants. And looking more specifically at infants and children who've died related to abuse, you'll notice here on the top graph a trend in increased child fatalities across the time period 2015 through 2019, with the most recent fiscal year data identifying an abuse fatality rate as 2.5 per 100,000 children, so those children dying directly from abuse or neglect. And again, we see on this bar graph listed below that infant age group accounts for the greatest proportion of child fatality victims relative to older children. And we'll talk a little bit more about this later, but primarily that fatality rate is related to lethal abusive head trauma, formerly known as shaken baby syndrome, whose constellation of neurologic sequelae is really often non-survivable. And so certain risk factors emerge as predominant in abuse and neglect cases. Nearly a third of children experiencing fatal abuse have caregivers with substance use issues, other psychosocial adversities, mental health issues, poverty, prior child welfare involvement, all deemed contributory. And then finally, this bar graph on the bottom of the slide is the age distribution of abuse perpetrators. And so what you may not realize is that the majority of abuse victims experience maltreatment really directly by a parent or a biological relative, a direct caregiver. So that concept of stranger danger is largely a myth. You're more likely to be abused or neglected by someone directly responsible for your welfare and well-being. And here on this slide are some pretty striking and possibly disturbing illustrations of child physical and sexual abuse, including pattern injury, skin bruising from slap marks, palatal petechiae from forced fellatio in sexual abuse, and a torn labial frenulum from forced insertion of a bottle to silence a crying child. And my point is not to distress you, and maybe I should have provided you a little warning before showing this slide, but rather my point is to emphasize that some child abuse is obvious. It's at least recognizable based on external exam alone, or based on an obvious injury sustained by the child. But those obvious injuries represent really only a small proportion of those seen in abuse victimization. Most injuries are not externally visible, involving, for example, central nervous system or abdominal insults. Most are subtle, most evade detection clinically. They're misdiagnosed or under triaged at levels both at the medical system and on the child welfare response. And so missing abuse undoubtedly has profound medical and societal implications. And studies demonstrate that the majority of child abuse victims are actually not treated in dedicated children's hospitals, but rather they're first assessed in adult or community-based emergency departments, often lacking that skilled pediatric specialty trained clinician who may have the knowledge or expertise around abuse recognition. So studies demonstrate even when abuse is considered on the differential diagnosis, the actual medical evaluation may be inappropriately performed because of a lack of knowledge or lack of resources. Sentinel injuries is a term specifically used to refer to medically minor trauma like skin bruises or intraoral injuries that are often dismissed, but unfortunately associated statistically with a high risk of future potential escalating violence. Many providers are not even familiar with this term or with this concept, that of medically minor injuries preceding worse, often fatal later abuse. And several studies demonstrate providers lack uniformity in recognition and evaluation of those injuries that are really the most common warning signs or harbingers of future abusive injury. And so even when abuse-related care is delivered at premier children's hospitals, disparities persist and issues with detection persist. And I've included here on this slide one of the most famous studies by Joanne Wood, a mentor of mine from CHOP, specifically comparing skeletal survey performance across 40 children's hospitals using the FIS database. And results demonstrate really tremendous variability exists with respect to how child abuse screening is performed and what it consists of, really supporting the need for enhanced abuse evaluation standardization efforts and increased medical provider education around abuse recognition. Many of you may be familiar with the wealth of published literature and the prevalent societal view that medical providers overassess and over-refer those children of minority racial ethnic backgrounds to Child Protective Services for abuse-related concerns, compared to Caucasian children, even those who present with the same injury constellations. And so those concepts of cognitive implicit bias as being prevalent across the medical and child welfare systems exist. So why might variability in the medical evaluation of child abuse be a problem? And let's conceptualize this just for a few moments, what we're actually talking about when we refer to child abuse victimization. The mechanisms involved inform the expected clinical injury patterns and then subsequently the screening guidelines. So I mentioned that the leading cause of abuse-related fatalities is abusive head trauma, formerly known as shaken baby syndrome. So that's a violent acceleration, deceleration of the head and neck, resulting in intracranial injury, subdural, subarachnoid hemorrhage, hypoxic injury, coup contre coup brain contusions, and retinal hemorrhages, all of which are illustrated here on this slide. That head injury, though, often doesn't occur in isolation. There's common extracranial abusive findings, like rib fractures, posteriorly or laterally placed, for example, when an infant is aggressively squeezed during a shaking event. Similarly, yanking or pulling or using an extremity as a lever during abusive shanking can result in classic metaphyseal or bucket handle lesions demonstrated on this exemplary radiograph. And in contrast, when we think about our older toddlers, picking them up isn't so easy anymore. They have greater head and neck control, less disproportionality in head size compared to their body. So the abusive target becomes the abdominal organs, and our toddlers are more likely to sustain and succumb to abusive abdominal injury, like a liver or splenic laceration. And so abdominal trauma is the second leading cause of death from child abuse. So all of those aforementioned injuries are internal, not visible to the naked eye based solely on your physical exam. So how do we detect them? And so for one, the American Academy of Pediatrics has produced several evidence-based national best practice clinical guidelines over the years, detailing the components of occult injury screening evaluations. And occult meaning clinically asymptomatic trauma. So the AAP endorses a broad sweeping polyorgan injury evaluation consistent of head imaging, imaging of the skeleton, and lab studies then looking at abdominal function like liver and pancreatic enzymes, for example, to detect derangements that might be consistent with blunt impact abdominal trauma. The guiding and fundamental principle is that your external exam may not suggest the extent of your internal injuries. So when you do identify an injury like a fracture or a bruise, it's recommended that other parts of the child's body be screened for occult injury, like their head, or that other forms of abuse be considered. They really emphasize this multi-organ system approach, neuroimaging, skeletal imaging, lab studies for abdominal trauma. Don't be fooled by the external appearance. Those are all fundamental components. And certainly, identification of additional injury enhances child safety concern and may impact your abuse diagnosis. So screening neurologically asymptomatic suspected abuse victims by head imaging, CT, MRI, and routine whole body X-ray skeletal survey performance as standard components of occult injury screening has been really recommended for nearly 20 years at this point. And what this means then is that typical infant and toddler abuse evaluations are pretty intensive. They consist of ensuring identification of all potential areas of organ injury, CNS, skeletal, abdominal. You can see here I've listed a typical infant abuse evaluation with head imaging, skeletal survey, and lab studies compared to a toddler evaluation, skeletal survey, and lab studies. And this really should be performed for every patient every time. And so while this may be self-evident, and most of you know this already, many child abuse cases also involve reporting to Child Protective Services and to law enforcement or social work involvement to help investigate those abuse concerns and then implement supportive services for a family unit to ensure that a child is ultimately kept safe. Sometimes, though, this means having to admit a child to the hospital while we're awaiting a safe disposition from involved external agencies. And that unfortunately can prolong length of stay. So studies have shown also that abuse is not discriminatory, that we should think about the safety of other children or infants in the home environment when assessing that indexed suspected victim of abuse. And we should also extend those occult injury screening guidelines to those siblings and household contacts. So included in the AAP best practice clinical guidelines is the recommendation to apply this same logic to any age-eligible sibling or household contact of a victim of suspected abuse. And while this seems to make intuitive sense, I hope, unfortunately, this has been an area of controversy. Many healthcare providers see really diminished value in performing all of these radiologic studies for a household family member. It's been suggested they're too costly, they're even unnecessary, since many child abuse cases involve reporting to Child Protective Services regarding that indexed child and subsequent family intervention. The value has been questioned. Does it really change investigative outcome? And so we don't have time to explore this in depth, but suffice it to say that when these national clinical best practice guidelines detailing what constitutes abuse evaluations have been protocolized via, for example, a clinical pathway, they're effective. Disparities are reduced, detection of abusive injuries is increased, overall care delivery is improved, and I've included here some of the more famous publications on this slide for you to review in the future. So, why do all of this? The lab work, the x-rays, the head imaging. What's the end goal? Why is it important? And why is it important for today's talk? So, the goal is really to keep children safe, but also to reduce the tremendous downstream impact that child abuse and neglect has for society. So abuse victimization is tremendously costly. We have the immediate quote unquote costs to the victim and the family. So for example, an injured child who suffers abusive head trauma, they may sustain irreversible brain damage. They may need rehabilitation, special education, physical therapy, occupational therapy, even lifelong nursing home care. Costs, though, are qualitative and quantitative. So abuse is an adverse childhood experience, an ACE. Many of you are familiar with the ACEs literature, associated, unfortunately, with a whole host of costly physical and mental health conditions that follow a child well into adulthood. Even shortened lifespan has been reported in abuse victims because of comorbid conditions in adulthood. But there are practical costs, too, an economic burden related to lost productivity and really exorbitant resource utilization across the healthcare, social service, child welfare, criminal justice, and even educational sectors. And so some preliminary research looking at the cost of child abuse has followed a pyramid schema as paralleled here on this slide. Some older case reports and case studies looked at the individual family level impact. And there were some larger hospital-based studies looking more specifically at costs to care for abuse victims versus those presenting with accidental trauma. Several larger studies have looked at public health-based data and Medicaid expenditures, and then even studies reporting statistics, cost-related statistics at the state and national level. So multiple studies to date have examined the economic burden of abuse and neglect in diverse fashion, really providing variable estimates of the financial impact of treating both tangible and intangible consequences of victimization across the lifespan. And they've differed with different calculative methodologies and study methodologies. So I'll go into one or two very quickly. The Fang et al. Study is arguably the most famous of the cost-related studies published to date. And so while we can't spend time detailing the intricacies of their methodology, because we will do that for our study, they concluded the estimated average lifetime cost per child abuse victim when assessing medical costs and theorized productivity losses was over $1 million, as detailed there on the slide. And similarly, using that National Child Abuse and Neglect Data System, Federal Data Repository I mentioned earlier, using fiscal year 2018, Fleeka et al. Indicated the national lifetime cost associated with those substantiated abuse cases and child fatalities across the U.S. exceed $591 billion. So several studies have focused specifically on abuse-associated healthcare costs, with data suggesting that abused or neglected children have longer hospital lengths of stay, higher injury severity scores, higher morbidity and mortality risk, more extensive post-hospital rehab needs, and both increased hospital charges and costs compared to those peer hospitalized children who sustained accidental injuries. And so hospital-based costs to care for children who sustain abuse-related injuries are significantly greater than the other pediatric population. And costs to payers after abuse-related hospitalizations are also exorbitant, with a recent claims-based health service utilization study suggesting abuse victims incur on average Medicaid expenditures that are almost $3,000 higher per year compared with other peers, accounting for approximately 9% of all pediatric-related Medicaid expenditures. So I've listed one of those hospital-based sentinel studies here on this slide. What can we do really to offset abuse-related costs? And that's where our work comes in. Exorbitant abuse-associated cross-systems expenses really could be partially offset by enhanced investment in abuse prevention initiatives. So focusing on earlier, broader identification of suspected child abuse victims through, for example, better screening tool development or implementation really of systematic, standardized, hospital-based evaluation protocols. But many institutions protocolizing abuse-related evaluations have faced concerns, and that's primarily been with respect to the impact of resource-intensive screening recommendations on already overburdened hospital staff, facilities, and equipment. We talked a little bit earlier, a couple minutes ago, that children presenting for abuse-related care frequently have high care needs. Multiple subspecialty consultants are involved, and also ancillary support staff like social workers to address really those complex abuse-related health and psychosocial issues, to facilitate communication with involved child protective services or law enforcement investigators, and then to coordinate safe disposition. So this often, though, takes time. It's associated with prolonged length of hospital stay and a need really to sort out those safety concerns while a patient is safely admitted to the hospital, which can raise obvious cost concerns for reimbursement. So frequently controversy exists then regarding the cost of abuse evaluations versus revenue. Is all of this abuse screening really worth it? The total charges billed versus the monies recouped, especially when we think about liberalizing those recommendations and also screening sibling and household contacts, whose evaluations, as I mentioned earlier, might seem unnecessary or low yield. And it really forces the hospital to question, is it all worth it to perform these robust abuse evaluations? And so our response to that, though, is arguably, might earlier abuse detection through enhanced screening actually reduce some of those long-term societal costs and societal impact that I detailed earlier? So the answers to many of these questions are unknown, but we set out to try to find them. And so a paucity of literature exists regarding the impact of standardized abuse screening on hospital costs, on net revenue, and on occult injury detection, particularly among evaluated siblings. So what we set out to do then, the objectives of our study, were to assess abuse evaluation metrics. So the existing performance of head imaging, skeletal surveys, and lab studies at our institution. Assess how standardized occult injury screening performance then impacts costs to care for suspected child abuse victims at our Level 1 Urban Pediatric Trauma Center. And then to think about what areas appeared high resource intensity, what areas were inefficient, and then inform opportunities for potential hospital resource reallocation or redistribution and cost savings that would ultimately support continued evaluation of suspected abuse victims in accordance with national clinical best practice guidelines. And then finally, we wanted to compare total hospital costs to care for abuse victims versus the net revenue or monies recouped. So this is a brief timeline here of our project, including the pathway development process, which occurred in phases. So in 2017, there was some initial interest in hospital provider education around child abuse awareness and around neuroimaging recommendations. Then a pathway development team specifically convened in 2018. And throughout 2019, we implemented an educational bundle, including a series of lectures and feedback sessions to the hospital staff that were intended really to raise awareness about pathway components. And then finally, the pathway implementation occurred in 2019. And as you can see here, we had two PDSA or Plan, Do, Study, Act cycles, iterative process reviews, where we looked at the initial pathway performance, compliance data, and issues that arose. And so this is a very busy slide, and I don't want you to get lost in it. With the next couple of slides, we'll detail in a little bit more depth. But for example, shortly after pathway implementation, we had a meeting to refine admission criteria, for example, for abuse patients to the inpatient wards. We refined our sedation plan for neuroimaging studies, and we even identified certain subpopulations of infants that could be exceptions to the full abuse injury workup. We went through this very detailed process in order to standardize what we were doing at Nemours in line with national clinical best practice guidelines that I've reviewed for you. And here's a schematic ultimately of our pathway document for reference with our patient population delineated, the emergency department process, and then the disposition plan. We also included specific recommendations around neuroimaging performance, laboratory studies, other involved consultative services, again, specifically utilizing the 2015 National Clinical Best Practice Guidelines for Child Abuse Evaluations published by the AAP. We also detailed here specific regimen for studies to be performed for siblings and household contacts. And you can see here there's an age-based algorithm, which also takes into account clinical exam findings and historic suspicion. And the entirety of our occult imaging screening recommendations developed for our specific pathway was based on those current AAP recommendations, evidence-based medical literature, but also with input from our multidisciplinary team pathway group. So, not surprisingly, pathway implementation was associated with increased performance of the studies recommended by the AAP National Clinical Best Practice Guidelines, including for skeletal surveys and for head imaging, illustrated here and on the slides to follow. And so you'll note similar trends on this SBC chart, this statistical process control chart, and the one to follow, in that we seemed to positively impact provider performance of the recommended imaging studies as early as when discussions actually started around the need for the pathway and that educational bundle that I described. As you can see, if you look at our mean data, we started out baseline performance of skeletal surveys was around 64%, but during our initial educational bundle, that pathway planning phase, our mean bumped up to nearly 80, and then after pathway implementation, we were hovering around 97% for skeletal survey performance. And we see similar trends here with our neuroimaging, where we were really only neuroimaging patients around 30% of the time before the pathway was implemented. We started talking about it and having more education and discussion. Our mean went up to over 70. And then finally, after the pathway was implemented, our means hovered around 92%. But now the cost focus. So how much did all this occult injury screening actually cost? And how does occult injury screening generally impact costs and revenue and reimbursement at the hospital level? So to answer that question, we first undertook a retrospective chart review of children less than 2 years of age presenting to our urban level 1 trauma center who had suspected child physical abuse concerns. We looked at the population time frame was 10/1/2018 through 7/23/20. We really wanted to ascertain facility, provider, and radiology level hospital costs related to occult injury screening performance versus how much net revenue and monies we actually recouped. So the abstracted variables are listed here. We looked at some demographic characteristics, whether the patient was an index victim versus a household sibling contact, insurance status, length of stay. We then classified their injury findings, head trauma, skeletal trauma, polytrauma. We assessed charts for external physical exam findings or clinical symptoms, which specific studies were performed, which providers were involved, and then to approximate the hospital resource demands, which are defined as cost and time, associated with each component of our abuse screening on the pathway, we utilized a novel technique called time-driven activity-based cost analysis, which I'll refer hereafter to TDABC. So the TDABC analysis calculates unit costs of supplying capacity by an entity, so in our case, the hospital, and then the time required for each activity performance. So in this study, the components then of the occult injury screening that was stipulated on our pathway. So as a preliminary step for TDABC, we reviewed that standardized protocol for occult injury screening, the pathway that I referred to earlier, which was implemented in 2019. But importantly, next, we process flow mapped that ED-based child physical abuse standardized protocol in order to identify the necessary time input for our TDABC calculations. So content experts from pediatric emergency medicine, from child abuse pediatrics, radiology, nursing, social work, convened to map out each individual aspect associated with the standardized protocol components on our pathway. And we created process timestamps for each component. So I know this is a busy slide, but it's meant to kind of show you the swim lanes here. So if we were to map out from a process perspective, every element of our physical abuse pathway and every provider involved, this is what it looks like. So for example, we looked at time from ED arrival to nurse triage, time from nurse triage to ED physician assessment, time from ED physician assessment to the performance of skeletal survey, MRI or CT, time in radiology, time from study performance to the radiologic interpretation, time to discharge, etc. So the timestamps that we approximated were based on minimum and maximum time to complete each activity. And for some of that information, we had automatically generated timestamped data from our electronic medical record. So we used that when available. And when lacking, we really confirmed by our consensus opinion. And so the timestamps reflect minute ranges. So for example, 20 to 60 minutes to complete a CT in the radiology suite. For provider input, specifically, for example, social work time per patient, we actually timestamped that with a maximum of 720 minutes to represent dedication of an entire social work shift to abuse-related patient care, for example. And so any dedicated social work time beyond 720 minutes was not subsequently entered into these TDABC calculations because we considered it at max. So what we did then was develop 3 patient X benchmarks. I'll call them theoretical patient X. And so we mapped using either only the maximum timestamp, only the median, or only the minimum timestamp. And so we respectively refer to these as like a low time, quick care delivery patient, a medium time, medium care delivery, and then a high time, slow care delivery physical abuse victim who was going through our pathway. To approximate then the time and costs associated with completion of the occult injury screening components. And so we approximated these timestamps to the nearest whole minute. And here I'm just showing you a little bit in more detail. For example, you have there with the blue sticky notes, running labs, transporting, performing the skeletal survey, performing the head CT. And while it's a little bit small, the font above it, you can see the time range. So we estimated that it would take 30 to 40 minutes for skeletal survey performance. For example, and we accounted for time to read the images, to examine the patient, to make a plan. You can see this was really a very in-depth process to try to timestamp and process flow map our existing pathway. So to review in a little bit more depth, TDABC is used then to determine cost of care to an organization. So we're not looking at charge here immediately. We're trying to determine the cost to Nemours to care for this patient population. And so we input time so that we can really understand the patient duration with staff and their duration at the facility and their interaction with equipment. So it's fundamentally based on this CCR, or cost capacity rate, multiplied by the time to generate a cost. So we can apply this CCR concept to staff, to buildings, to equipment. So for staff, it's their cost to the organization over how much productivity they have, their working capacity. We can apply CCR to the cost of a building or equipment, or per square footage, how much it costs the institution to support that process step. So then taking a combination of staff and assets, these CCRs then can generate a cost per unit. So in a bit more depth, I mentioned that this TD-ABC analysis is based on two cost drivers. So the prices of resources that are used to affect the cost capacity rate, and then process flow efficiency. So when we think about defining cost capacity rate, it could be an employee cost for the time committed to patient care. It could be a supply cost, an equipment cost, a facility cost, derived then to a cost per minute designation. So let's just walk through an example here. So to cost out MRI brain performance, for instance, the included elements in the CCR calculation are the cost of the machine, the cost of the time committed to transport the child from the emergency department to radiology, the time spent in the MRI scanner, the time for the study to be interpreted and that result to be imported into the medical record, the salary of radiology technicians, the supply of radiology technicians, costs associated with sedation medications used during the MRI. And all of those additive costs that I just detailed were then multiplied by each individual study subject's time for MRI performance and divided by 60 minutes. And then we defined an average per minute CCR, or per minute cost capacity, for MRI performance for all our study subjects. The CCRs were calculated similarly for CT, for X-ray, for skeletal survey performance. When we thought about the ED facility CCR, we thought about hospital departmental square footage, the number of rooms, the supplies needed to stock rooms. And then when we thought about provider type CCR, including physician, nursing, and social work, that was really based on average salaries divided by productive time. So that excludes vacation and sick time off, and that's all thought of as non-productive time. So for example, here again outlined, when we were calculating ED physician CCR, for example, we looked at the average salary divided by productive time, 50-hour work week, 13 shifts per month, and then costs were approximated to the nearest whole dollar. So what I'll be presenting in a few moments is total cost and total time associated with child abuse case treatment in our emergency department. And so when we think about we then looked at we defined an episode of care, which really would be that abuse presentation, defining length of stay from admission to discharge, which ranged from multiple days. And then using that episode of care, we were able to look at total hospital costs and then contrast that with net revenue, or the expected monies recouped. So in sum, TD-ABC basically determines costs to an institution or a business to supply a certain product. And it takes into account the resources needed multiplied by time. So in our case, we're looking at the process of the physical abuse pathway, which is heavily emergency department based. We're inputting all of those resource related costs, which were personnel, facility, departmental, supply, and then we're multiplying it by time. So time included that time-stamped data, that physical time that the patient was in room 18, for example, in the emergency department, but also that resource time associated with the ED-based process steps, all of those physical abuse screening steps. We're approximating or determining to the best degree of certainty time versus resource input for a particular patient using all of the metrics that I just described. We also have some simple descriptive stats too. Okay, so now into the results. I'll highlight a few things here on this slide. So we did the CCR calculations, and we found that ED facility CCR was around 84 cents per minute for hospital treatment of an abuse victim. In contrast, when we looked at neuroimaging, it costs the institution almost $5 a minute to perform an MRI versus a CT scan, which costs slightly over $1. And then we look at average physician per minute cost to treat a child abuse victim, which is around almost $2, in contrast to nursing and social work involvement, with social work costing 84 cents per minute. So we talked about those theoretical patient X's, the low time, quick care, the high time, slow care. And you can see here that the theoretical patient, the low time patient who underwent the most rapid abuse evaluation, sustained hospital costs of $1,610. In contrast, when we had a slow care delivery patient, the patient who theoretically took the maximum allotted time to go through the physical abuse, their costs to Nemours to treat them resulted in almost 3 times an expenditure, or almost $6,000 for total hospital costs, highlighted in red below. So I've bolded some pertinent findings here about our population. As I mentioned, we looked at 199 children in more depth. So the majority of our study subjects were male. Most had public insurance. We had pretty identical proportions of Black and Caucasian patients. Most of our study subjects were index victims of abuse, and I bolded in the lower portion of the graph the proportion of children presenting with head trauma versus skeletal trauma, cutaneous or polytrauma. And so almost 22% of study subjects actually had no diagnosed injuries, and they may represent either siblings and household contacts or those patients who were referred for an abuse evaluation who ultimately had no injury diagnosed. If we look in a little bit more detail at those index patients versus siblings and household contacts, 27% of siblings had unanticipated traumatic findings. We see 3 siblings here with skeletal trauma, 5 who had cutaneous trauma. Most had no diagnosed injuries, and you can see a bit lower down when we look at exam findings, really no siblings had any external signs of trauma. If we think about external signs of trauma for index victims, almost 63% had external head trauma signs, so 17 out of 27 who had head trauma total. And then when we think about those head trauma victims, over 44% of them, 12 of 27, actually exhibited either altered mental status, vomiting, or seizure activity. When we look at those with polytrauma, 59%, or 13 of them, exhibited either seizure activity, vomiting, or altered mental status. And then almost 82% of our skeletal trauma victims exhibited some pain or distress through crying or weakness or disuse. So now looking a little bit more specifically at the time, the overall total ED time for each abuse case ranged from 62 to 725 minutes, and social work time ranged from 44 to 720 minutes. Pretty wide ranges here. We looked then, this is a busy table, but I just want to draw your attention to the circled items. We looked at resource time allocation by diagnosed injury type. So for polytrauma, total ED time was ranging from 169 minutes to 281 minutes, social work time 278 to 720. If we look a little in the middle there, total emergency department time for head trauma cases ranging from 169 to 426 minutes approximately. And then if we look at the bottom of the chart, total emergency department time dedicated to assessing skeletal trauma was similar, with a minimum time spent of almost 129 minutes to 429 minutes range. Then we looked a little bit more specifically at net revenue by injury classification. And you can see here there was a broad range. Our revenue for head trauma was anywhere from $778 to almost $158,000. And we've got really wide ranges of revenue here across the injury classifications. And then importantly, across the entire study period, total additive hospital costs for all subjects versus the total net revenue actually resulted in a net positive margin. So while it was costly to the institution to treat this very resource-intensive population, the institution actually recouped a net positive. So things to discuss. While multiple studies have looked at the economic burden using varied techniques, our study is really the first analysis of ED-based standardized occult injury screening associated costs versus revenue. And we're the first to implement this novel TDABC technique. Our results suggest really that this resource-intense broad screening, while costly, is an effective tool to increase abuse identification without a significant net negative revenue burden for hospitals. And certainly you saw the data is kind of all over the map. There's opportunities that exist for resource reallocation, which may potentially increase our process efficiency and really permit continued performance of occult injury screening in accordance with national clinical best practice recommendations. So through this analysis, we identified that hospital costs, which we define as that time and resources in dollars, is really variable. It's financially substantial, resource intensive, but it's likely reflective of these complex care needs of our population, who also has really in-depth psychosocial and safe discharge related barriers that necessitate coordination and attention. Not surprisingly, when we looked at those hospital costs by injury classification, there was variability. There were increased costs with the most severely injured children, such as those with head trauma, versus those who didn't have diagnosed findings. And so across the board, though, cases were associated with really prolonged social work time commitments that often exceeded a single shift of a clinician, likely related to that coordination of complex social and discharge needs. And so most importantly, though, from our perspective, the standardized occult injury screening identified injuries that were not apparent by external physical exam alone and not apparent by clinical symptoms alone. We talked about identifying additional unanticipated abuse victims among nearly 30% of all siblings or household contacts, highlighting then that study performance in this population is of high value, really contrary to skepticism that I introduced earlier, that sibling evaluations are unnecessary or excessive given the social services intervention for the rest of the family. So arguably, our results really support the premise that broad and standardized screening potentially results in higher upfront hospital costs, but might actually mitigate a future cost burden. And so TDABC is traditionally employed in industry, and our calculations suggest areas of inefficiency with those wide ranges of min and max numbers. So one possible solution could be maybe deployment of additional clinical staff, like additional social workers or emergency department physicians, purchase of additional equipment, which may improve rapidity at which abuse evaluations can be accomplished, which might reduce costs. But there are other alternative suggestions to explore, like maybe an outpatient avenue for assessment for patients, or potentially advocating, there may be areas where cost savings are external to hospital influence, like waiting for that safe discharge from Child Protective Services. Maybe ultimately those issues might be areas where hospitals really have little external leverage. And then finally, an unanticipated study finding that I mentioned was really the net positive revenue generation or monies recouped, even when the majority of our study subjects had public insurance. And so this finding is consistent with prior literature that abuse-related care is costly, but also suggests that fears about robust screening should not deter institutions from implementing broad and standardized screening efforts. We had some limitations. The retrospective study, they're obviously using financial data that may reflect geographic trends like salaries utilized in provider calculations, specifically based on the state of Delaware. Reimbursement reflected specific monies recouped regionally. So this may vary from other geographic locales, but despite this, we really feel our cost-related principal conclusions are highly likely to be generalizable, that there is variability in occult injury screening costs. The studies are time burdensome with a time burdensome staff commitment and resource intensity, but a likelihood of additional victim identification. So in conclusion, we've answered the question around hospital costs associated with abuse evaluations. They're substantial, variable, resource intense. They require prolonged physician and social work commitment, but importantly, they're of high value. We identify internal injuries when our external exam is absent, but there are areas of resource and time inefficiency, and potentially those should be our targets for next steps for future resource allocation, really to support performance of national best practice guidelines. I'd like to thank the Pathway Work Group and most importantly, the Nemours Finance Group, Jane Zent, Paul O'Brien, Alexander Kirk, our research assistant, Claire Loydell, and ED physician Arazuzo Marodi for all of their input and dedication towards this study. So thank you. I know we're right at the end of time. I apologize about that power outage, but happy to take any questions if anybody has any.
Thank you so much, Dr. Deutsch, for this amazing presentation and really incredible analysis and research. Really, congratulations. This is fabulous. Any question from the audience? Well, I have a question directly related to the research. Do you think there is a way of estimating the long-term cost, or I think you looked at follow-up costs, but were they short-term follow-ups, or was it like years?
Yep. So we looked very briefly at some short-term follow-up data because, in line with the current national clinical best practice guidelines, the American Academy of Pediatrics recommends that if you perform skeletal imaging for an abuse victim, that you should really repeat that within 2 to 3 weeks. You may identify healing injuries that were not radiologically apparent on your first set of studies. So our pathway actually includes a protocol where we see our physical abuse victims who are age eligible and imaging eligible back in clinic for follow-up x-rays. So we looked at a very select group for that follow-up data. I think we're in a unique position here, being the only children's hospital where we have many children who stay in network and stay, remain continuous with the institution for the totality of their care throughout childhood into adulthood. And I think we potentially could look at longer term costs associated, for example, with our abusive head trauma victims who then remain as Nemours patients receiving rehabilitation services, PT, OT, speech, for an indefinite period of time. We certainly have a large cohort of patients. So we didn't look specifically beyond that 2-week mark, but I think that's definitely something we're interested in.
Thank you. So on a more general, issue, have you started looking at 2020, fiscal year 2020, and the effect of COVID, of the lockdown on children abuse?
Yeah, so unfortunately, the federal data that's compiled through NCANS, through that national, the federal repository I mentioned earlier, lags about 2 years behind. So we won't have the official report on what the trends that occurred in COVID closer to spring 2022. However, that being said, several of my colleagues within the child abuse discipline have looked at trends in different geographic locales and have performed a few multi-center studies, which really have suggested that while the total numbers of children during the early pandemic period presenting for emergency department care decreased, the proportion of children presenting with physical and sexual abuse concerns during that time period was disproportionately large, and that the injury severity scores are really profound in the children that are presenting for care, which suggests that COVID had a negative impact on the safety of our children. There was a CDC MMWR report as well reflecting similar findings and statistics that came out a few months ago. What we're seeing clinically here at Nemours is certainly an uptick in serious physical injury. We've had several torture cases over the past couple of months, and I think some of those, you may be familiar that the media coverage suggested that initial hotline reports early on during the pandemic related to child abuse and neglect concerns had actually decreased in many jurisdictions across the country. I think now we're starting to see an uptick in reporting and in identification. So certainly the prolonged chronic stressors families are facing now with hybrid programs, and there's more interface of children back with school personnel and those mandated reporters who really account for the majority of child abuse hotline reports across the country, I think are all impacting the increased rates of abuse and neglect that we're seeing now.
Thank you. Any other question? Well, hearing none. Well, thank you so much for your presentation. We certainly learned a lot. And thank you for all your work.
Great. Thank you so much. Thank you for the invitation. And I apologize for our bizarre.
No problem. No problem. You arrived at the end.
Thank you.
You completed it. Thank you so much.
Thank you.
Bye.